Hey, everybody, this is John Marshall here in Washington, D.C., where nothing is normal lately. A little bit rainy today, but we need it, so maybe it'll wash away some of our sins. But Oncology Unscripted is fortunate enough today to have an amazing guest, Dr. Thomas Powles from London. So it's a little later in the day where he is than where I am. And Tom has really led the charge in innovation in treatment with GU cancers. And I was first attracted and wanted to interview him, not only because he's a famous social media guy, he's really had a major impact on information sharing in our cancer community, but really because of the clinical trial that he oversees. But first off, Tom, welcome. I'm hoping you're having a lovely day in London. We love it there. Our kids live there. Do a quick introduction of yourself for our audience.
Well, John, firstly, I've followed your work for many years, and I'm incredibly honored to be here with you and the amazing things that you've done. And I'm very happy to join you. I'm Tom Powles. I'm an oncologist in London. I've led a number of different trials. Some have been successful, many have not been successful. And I also have collaborated with a huge number of people, and those trials which I have led have clearly been a huge team effort. And we're making, as you said, in GU cancer, a big charge towards curing patients with bladder cancer. We've done very well in kidney cancer, but we haven't quite got there yet. And of course, prostate cancer is a complex beast, but huge numbers of new therapies. So really exciting times in GU cancer.
Totally. So in MRD testing, let's jump right into that, is that, I think of adjuvant therapy as one of the most inefficient things we do. So on one level, some people were already cured by our surgical team members if it truly is postoperative adjuvant. On another case, some patients are not cured despite receiving therapy. They have microscopic metastatic disease and relapse anyway. But then there's that wedge of people who we do fix. We treat 100 people to help, I don't know, a quarter of them, right? And so how do we find the right patient to be treated? And this is where, at least in GI cancers, we're increasingly looking at MRD, and it's really quite controversial as to whether this has value or not. And I think of the study that you have presented and continue to update around this in GU cancers, to me, is a demonstration of just the value of it. So maybe drill down a little bit on that study.
So John, first, before I do, I'd like to agree with you. I think the next generation of oncologists will look at the way we select patients based off lumps on X-rays to define the presence or absence of disease. That's a long way from reality, probably in the same way as we currently look at doing surgery without anesthetic as a similar, how can you treat that 70% of patients who have no chance of relapse, giving them a 20% chance of life-changing toxicity to try and help the 30 with disease. And of course, if you focus on those 30 with disease, if you have a 10% absolute survival benefit, but you're dragging along the 70% at no risk, you can actually double, triple that benefit from a 10% to a 30% survival benefit. So it's not just all about the sparing those patients who don't need treatment, it's about improving your hazard ratios. And that's absolutely crucial. But then, of course, there's the sensitivity and specificity of the test that you use. Radiology is obviously a very, very good test because if you've got big lumps on an X-ray, you know you've got cancer there. But of course, post-operatively treating unselected patients, we're scrambling around in the dark. We currently hope that a pathology sample will define high and low risk disease, not biology. How big was it? Which of course is completely, in my opinion, hopeless. And so we're treating those patients who have bigger cancers because we feel they're at higher risk. What about if we can develop an MRD test, circulating tumor DNA, using an informed approach where we do whole exome sequencing on the primary tumor, we identify up to 16 mutations, and then we track those mutations with time. Can we identify those mutations in the blood? And the answer is yes, we can. And what is the positive predictive value and the negative predictive value? And it turns out they're both pretty high in adjuvant setting in bladder cancer. And so essentially what I can tell you is that if you do an operation in bladder cancer, about 50% of the patients will relapse after that operation, and about the same proportion of patients are ctDNA positive after surgery. And actually, there's a very strong correlation. If you're ctDNA positive 6 weeks post-surgery, you've got about a 95% chance of relapsing. If you're ctDNA negative post-surgery, you've still got about a 25% chance of relapsing. But you can change that, because if you're negative and you track those patients and they become positive, they do poorly. But if they remain negative, they do really, really well. So the chance of dying of urothelial cancer, and this is data from the Tombola trial, it's also data from other prospective series, that if you track those patients who are negative, who remain negative, the chance of dying at 2 years or 3 years of bladder cancer is minusculely small. You know, it's 3 or 4%. The chance of relapse is still about 5 or 6%. So it's still there. It's not perfect in those negative patients, but it's still pretty good. It's very good in the positive patients. What we showed in a study called IMvigor 010 is those patients who had had surgery, successful surgery for urothelial cancer, and there was no evidence of disease on radiology, that 50% who were ctDNA positive, if they received atezolizumab, you could reduce the risk of relapse and the risk of death by about 40%. Hazard ratios between 0.4 and 0.5. But atezolizumab in unselected patients has hazard ratios of between 0.8 and 0.9. So it's that dilution of those negative patients, focusing on the positive patients. And then, of course, in those negative patients, atezolizumab had no benefit. Although many of those patients, 30% of those patients who were negative relapsed, atezolizumab made no difference because the risk was low. Now, if you track those patients, and in the upcoming study at ESMO in the near future, we're doing a repeat of the experiment prospectively. But if you're negative, we're continuing to track your negativity. And if you're negative and you become positive, you can then enter into the study. We hadn't done that before, and that's novel. And that will give us the reassurance that we've got those negative patients who remain negative, who do well, but those negative patients who become positive, can we salvage those patients also? Immune therapy in bladder cancer, there are two important components to it. Number one is we know by the time you've got measurable disease, the cancer's growing too fast, we lose many of those patients. So we have to go earlier, and that's why we're doing it in the adjuvant space. That's important. And number two is it does appear the biology of the disease is potentially more sensitive to immune therapy the earlier you treat these cancers. And so that when you put it together, we're hoping for great results. We've looked at other settings. We've looked at ctDNA in the neoadjuvant space. But that's more complicated because you can be ctDNA positive because of your primary tumor or your metastatic disease. So to define that better, we're now looking at urinary tumor DNA. We're beginning to get great results for utDNA. So if you're utDNA positive and ctDNA negative, you might have bladder-only disease. If you're utDNA negative, but you remain ctDNA positive, you may have had a pathological complete response in your bladder. We know many of those patients relapse, and that means you haven't got rid of those nodal disease, which is still micrometastatic. So it's the first chapter of a series of chapters, which I think is going to transform urothelial cancer. The last part to it, which I think is important, is monitoring those patients. And ctDNA clearance is an early indicator of good drug activity. And so in the future, we're going to be using ctDNA and not radiology to get ctDNA clearance and looking at, there's a study called the Modern Trial. Matt Gowski's leading that study, and he's comparing nivolumab to nivolumab plus a LAG-3 inhibitor, and to see if ctDNA clearance is higher with the combination. And I feel this is a revolution which is going to stand the test of time.
Well, I want to dig down a little bit on the whole biology question, because in GI cancers, we don't enjoy that sort of transitive result where something that works in the refractory setting, metastatic disease, will work in the adjuvant setting. And I actually think MRD positive is its own biology. And from a drug development perspective, one of the things that I'm leading here in the United States is a platform of MRD positive colon cancers where we can then test for novel therapies, because I don't think the old FOLFOXes and FOLFIRIs are the right answer in that setting. And I think you feel like what I'm just hearing you say is that you're sort of aligned with that. It's its own unique biology. different from, it's the difference between seeds and small plants, if you will. There's a different biology there.
I feel strongly that that's the case. When you drill down into some of the biology of the 010 paper, and we put that in Nature, not in a clinical journal, and the reason we went there is we did whole exome sequencing, obviously, because that's how we track the ctDNA using the informed approach. We also did RNA sequencing, looking at immune signatures, and we did immunohistochemistry. And when you pull that together, there was some indicator that there were some distinct biological features of the ctDNA positive patients compared to the negative patients. And as you track, which you can do with time, as you track with time, you can obviously see dynamic changes associated with ctDNA and the different mutations. So I do think that there are different biological components to this disease. I think that those patients who are ctDNA positive, it may not just represent lower or high risk or disease which is inevitably going to relapse that's not yet radiologically visible. It may represent its own distinct biology, which I think is worthwhile exploring. And in terms of coming to your trial, I don't know enough about GI cancer, but I do feel that exploring beyond these chemotherapy regimes is really attractive. And it may be, if you want to accurately identify early active signatures, MRD must be the best way of doing that. I think it's a really good way across different tumor groups of delivering positive trials for interventions which perhaps are, by the time you've got advanced disease, it's too late for some patients.
Yeah. And we were actually thinking even deeper than that, that maybe you begin to have disease agnostic interventions at MRD, that you might see some cross reactivity there. So fingers crossed that the setting that you have shown positively, the interventions around this will trickle out to other diseases. But I want to go one other place before we let you go, and that is we come from different cultures. We work in different cultures. In the United States, people feel like they have the right to whatever it is. So if there's an adjuvant therapy, we treat everybody, and we're incentivized, right, as physicians to treat people. That's how we make a living around here. Whereas in rest of world, this is very expensive therapy, and so we have to demonstrate positive impact. So on our side, we're having to show that it's okay not to give it. It won't work. And usually that requires very large studies to show that you're not even missing one person, right? The breast doctors do 1,000-patient studies to show a 1% improvement in whatever intervention they're doing. Whereas in our kinds of cancers, we're looking for anything that'll help. And our cultures are different. So talk a little bit, I know you know both cultures, you interact, and this trial is open across the various cultures. Where do you see oncology going? The rising costs of drugs, the limited access to these drugs around the world, the role that MRD might play to improve access around the world?
What a complicated question, and I'm going to do my best to answer it. The first thing to say is I'm a huge fan of the United States of America. I think it's an aspirational culture, and when one looks around the world, and I travel the world all the time, you look at the ambition and the aspiration, the dynamism in the United States of America, it's second to none. And I'm a great, great fan, and I spend a lot of time there. I'm also a fan of the FDA. And given a choice between the FDA and the EMA, I see advantages and differences between both. But I feel the FDA is a more pragmatic organization. And I have to say, I'm a great fan. In terms of drug development, I think the last 10 or 15 years has been transformative in the cancers that I've treated, and that wouldn't have happened with the universities alone. We weren't making amazing progress, and the incentive to develop multiple targets at the same time and doing parallel trials has been successful. And indeed, many of those trials that weren't successful, we've learned from and moved forward. And we wouldn't have been able to do those 1,000-patient trials with just the university structures that are in place. So at the moment, you can't do a study in Europe and the United States. It's almost impossible together in a university structure. I'm sure you wouldn't be able to do that in Asia Pacific, Europe. And then the final bit I want to say before I say the second part of what I want to say is that in the cancers I treat, median survival, urothelial cancer, 10 years ago, 1 year. It's now tripled to 3 years with a 30% CR rate. That's going to get even better next year, in my opinion. Kidney cancer, again, 15 years ago, 1 year, now 5 years. And that's not because of radiology. It's not because of better diagnostics. It's not because of better surgery. That's all because of drug development. So we have to look at that success and celebrate that and say, yes, it may have been expensive and it may be difficult, but what else are we investing in? We're investing in, dare I say it, arms. We're investing in banks, in all sorts. Isn't it terrific? This is a good investment. And going back to your former presidents, and of course I've studied Jimmy Carter and all the way through, that race against cancer that each of the presidents has tried to achieve, I think we're winning that race. And I think so that's very positive. On the other hand, there is a twofold concern that the no stone unturned approach, where I have to have received every drug, that approach is not helping many patients. Indeed, it's probably harming quite a few. And there are two reasons for that. Number one is there is this difficulty around, of course, families and aspirational societies saying, if it's there, I have to have it. But actually, my experience of third or fourth line bladder cancer, dare I say it, second line bladder cancer, is that that's a law of diminishing returns. And in the end, it goes wrong for almost everyone. And it's probably doing as much harm as benefit for many of those patients. And you and I have both seen many patients suffering from toxicity towards their end of life, trying to get more and more cycles in. I do think Europe is more pragmatic about that. And I do think if your median overall survival is 7 months, your response rate is 10%, and it wasn't significantly better from an OS perspective than placebo, I think Europeans and the EMA is much more pragmatic, saying we want to see more. And I think that's very reasonable. I also would like to make one caveat to that, is that occasionally those drugs that weren't great in the second and third line setting have turned out to be quite active in combination in the frontline setting. And the FDA is good at that. And I have examples where we've had underwhelming results, second, third line, with moving the frontline setting in combination, and we've achieved those survival advantages. So I think that pragmatic approach is important, but I do not feel that every patient needs every therapy, and I don't think every patient benefits from every therapy. One of the key questions when one looks from a European, a US, and a global perspective is how we assess PFS and OS endpoints. It's clear to me in the perioperative setting that we need to achieve OS. That's my feeling on this. I don't think disease-free survival as an endpoint is enough. Two reasons. Number one is you can give salvage therapy subsequently to those patients that need it. And number two is you're over-treating all those patients who are not going to relapse. And so for me, we need that. And I know many of my American colleagues feel DFS is important because that has a higher rate of not achieving advanced disease and avoiding advanced disease as a goal. I have mixed feelings about that. I think patients want to live longer and feel better. In the perioperative setting, if you don't have OS, you're not achieving either of those goals. So I think that's relevant. The last bit that I'd like to say around that issue, which I think is important, is that MRD has a really important way of achieving OS. You enrich those patients that need therapy, you put some patients in harm's way, but you do achieve OS. And in MRD studies, of course, OS should be the endpoint. And then the second part is you're sparing big groups of patients therapy who almost certainly don't need it. Treatment would be over-treatment. Achieving overall survival advantages in that negative subgroup would be almost impossible. And indeed, the risk is low. So MRD achieves those goals, I think, that we're looking for. And I suspect, John, in the future, we won't be talking about adjuvant therapy in the way we are now. I think we're going to be talking about patients with MRD or without MRD. And I think, as you've said in your study, those patients with MRD, novel trial design to improve survival, in the end, is going to be a really important chapter in where we go next.
I would bet if I had enough money to throw on the table, that in fact, MRD testing will become screening. And
Yes.
maybe in 10, 20 years, you don't even get your bladder taken out or your colon taken out, but you just get systemic treatment and make the cancer go away before it's a problem. But you and I can work towards that end
Yes, we
and
can.
put ourselves out of a job. So Professor Dr. Thomas Powles, thank you so much for spending your valuable time with us. You're clearly transforming cancer care through incorporation of MRD and innovative clinical trial design, and teaching us all about how we're going to go forward, including about how we're going to do that as a unified global medical community. So thank you again for the time you spent with us today.
It's a pleasure. I really enjoyed it. Thank you very much indeed.